Okay, so this is the rest of the chapter 18 lecture. There's not much left. We ended with talking about COPD. I believe we ended with this last slide. One of the diseases we didn't talk about was cystic fibrosis, though we've mentioned it. Remember, this is a genetic disorder. So most common lethal genetic disorder. There are, obviously we're going to focus on the respiratory issues, but you have reabsorption of sodium that's inhibited in the skin sweat ducts as well. Enhanced sodium transport across epithelial cells in the respiratory system, pancreas, and bile ducts. So not only does this affect the respiratory system, obviously you have effects with the skin sweat ducts, but also the pancreas and bile ducts as well. But again, what we're mostly focusing on is respiratory. So you end up with obstruction of airway passages and also the pancreatic ducts by this thick mucus, and we're going to talk about why. About 2 to 5% of Caucasians will carry this gene. It is uncommon in Blacks and Asians, so it's more prevalent in Caucasians. It's a recessive genetic disorder. We talked a little bit about autosomal recessive and autosomal dominant diseases a couple of chapters ago, really at the beginning of the semester. And again, for the most part, it's going to affect transport of fluids across epithelial cells. Okay, and again, predominantly we're focusing on the respiratory system. Okay, so where is the gene mutation? It's in a chloride channel. Okay, and again, we talked about channels or channelopathies, right? If you look at the plasma membrane, here's an example of a chloride channel. You can see these purple guys here are chloride ions, and you can see there's a higher concentration of these chloride ions inside the cell, right, and a lower concentration outside. If we talk about movement of molecules along their concentration gradient and diffusion, they're going to have the tendency to move this way. Chloride ions, or any charged molecule for that matter, cannot get through the membrane on its own. They have to go through a channel, right? So a specific channel. So this channel is only for chloride ions, okay? So this is showing you this normal channel here, okay? They move from the inside to the outside of the cell. If you have a genetic defect in this gene that basically makes that chloride channel, right, you have this non-functional mutant chloride channel, okay, which is unable to move these chloride ions from inside the cell to outside the cell, okay? And so what ends up happening is outside the cell, you get this sticky mucus that forms. And this is because, and I don't know if it says this on a couple of slides from now, maybe not, so I just want to make sure I say it now, the movement of the chloride ions outside the cell also affects the movement of water outside, right? So the thick mucus is really because there is less water out here, okay? But again, it is caused by a defective chloride channel, okay? So we're talking about our group projects, right? And I told you about causes and that you really need to specifically focus on the cellular, molecular cause of a disease. It's this. So if you had cystic fibrosis, you don't just say, oh, it's caused by genetic factors. No. What exactly does that genetic mutation do, right? What does it cause? It causes a defect in a chloride channel, to which now chloride ions can't move the way they should, and you get this thick mucus that builds up, and then you can talk about all the symptoms from there, okay? So when I'm talking about causes and when you guys are doing your project, that's the type of explanation I expect. Okay, so in terms of clinical manifestations, right, thick pulmonary secretions due to that thick mucus that forms because there is not enough water out there. You get frequent infections because of it, a chronic cough, also abdominal issues. We talked about the pancreatic ducts being also sort of blocked. And again, because of the effects on the pancreas, you also have effects on the GI system. If you talk about diagnosis, this skin sweat test can be used because we also said because of the defective chloride channel, it's going to affect those sweat glands, right? And so it can be used as diagnosis. Again, when you're talking about the clinical manifestations and the problems, you're more focusing on the respiratory and the pancreatic types of issues. But the skin sweat test is a method of diagnosis. For treatments, again, you're just treating symptoms here. So antibiotics for secondary infections that might form because of this mucus buildup, vitamin supplements, Again, pancreatic enzyme replacement, because that duct gets clogged or blocked and those enzymes aren't able to make it into the small intestine. Therefore, digestion is affected, right? So you're not able to break down proteins like they should be broken down and digest them. Okay, so that's it for cystic fibrosis. Again, remember it is a autosomal recessive disorder, okay? But we want to know about the pathophysiology of it. It is because of a defective chloride channel. Last thing that we'll talk about in chapter 18 here is bronchiectasis, right? And just, we're not going to talk, I think there's 3 slides on this, okay? So again, a term for excessive mucus accumulation, okay? And we just saw this mucus accumulation in cystic fibrosis. So you see this in different types of conditions, right? It leads to bronchial obstruction, leads to dilated bronchi that basically, because of the buildup of mucus in there, they become extra dilated. We kind of talked about this with the alveoli and COPD, right? And so once they get stretched too much, they can readily collapse because those walls get thinner and thinner. Repeated infections. If you talk about risk factors, blockage of airways, again, all this is kind of a little redundant. And again, can be caused by congenital or other genetic conditions like cystic fibrosis. Okay, so again, this is kind of like sort of this general term that you'll see this in different types of diseases, right? So again, things like cystic fibrosis will cause this. Severe persistent cough, we talked about this. If we talk about the phlegm or the sputum, right? I put this in here just so you guys can understand kind of what this is talking about. It's just a way to describe the color, okay? Right, dyspnea, we talked about this all along, wheezing, pleuritis, chest pain. If you talk about diagnosis, CT scan, right, chest x-ray, again, these are all the same diagnostic techniques we've been talking about all along in this chapter. Treatment, antibiotics, bronchial hygiene. So if you kind of look here, this is just basically showing you, I put this in here too because here I was talking about pleuritis, right? And we've been talking about the pleural space and the pleural a lot. So you can see the difference, right? So here's this visceral pleural, which is more the inner layer, and the outer layer here. But again, remember, you can get accumulation of fluid in there, you can get accumulation of air in there, and then it can press on the lung and cause various problems. If you look at the CT scan, right, you can actually see all of these enlarged, thick-walled bronchi, right? So you can actually see that in that CT scan. All right, and so that's it for chapter 18. So what I'm going to do now is I'm going to move and I'm going to give, basically I cut down the lectures for chapter 19, 20, and 21. So I kept them separate. So I'm going to kind of toggle through them and go over them. So you are responsible for all of what I covered here. So like I said, I cut out a lot of things from these last 3 chapters. I didn't even, not even covering chapter 22 at all. Okay, so let me go to chapter 19 right now. And I'm going to pull that up and let's talk a little bit about some of the things that are in here. Okay, so this chapter is on neoplastic, infectious, pulmonary vascular respiratory disorders. So I just wanted to, again, just make sure I mentioned some of them. And again, if you guys look back and at that, remember that chapter or that unit opener, that summary, right? It basically had that whole body and showed you all these different types of diseases. Make sure you understand that and know where these things fit in. Again, we don't want to think, or we should know that cystic fibrosis, right, is not a neoplastic or an infectious disease, okay? All right, so if we talk about, this whole chapter is talking about pulmonary disorders that are caused by things like growths, right? Neoplastic growths. We talked about neoplasms before in our just general cancer chapter. Infectious diseases. Okay, we'll talk a little bit about that. Abscesses and other vascular disorders. Like I said, I'm just going to kind of give you guys a little bit of an overview and hit a few of the main, more common types of diseases. So if we're talking about cancer, right, we can talk about malignant growths. Not all of them have to be malignant. And you can have benign growths, just like, again, anywhere else or any type of cancer, but again, focusing on the lung. infectious diseases, we'll talk about a few of those as well. Okay. What's going to happen here? Just like all of these pulmonary disorders we've been talking about, they're going to significantly impair oxygenation. And if you're talking about pulmonary vascular disorders, they can include alterations of blood flow, right? So either within the lungs or to and from the lungs, right? So if we're talking about, blood moving from the heart to the lungs, maybe it's not getting there, okay? Alterations in respiratory function associated with inadequate nutrition, another thing you can kind of think about in terms of concepts related to pulmonary disorders. Okay, so if we talk about malignant lung tumors in general, again, we probably know most of this stuff. Lung cancer is the leading cause of cancer death in the United States. Again, what's the primary risk factor? Cigarette smoking. There are other risk factors as well. These are very similar to what we talked about in terms of COPD, right? Environmental and occupational carcinogens like asbestos can cause lung cancer as well. There is a genetic component. If you have a sort of benign chronic lung disorder, it can then develop into a cancerous one. Diet, gender, all of these things will affect it as well. In terms of clinical manifestations, right? Obstructive pneumonia, again, dyspnea, we talked about this before. You can also, another sign is coughing up blood. We haven't seen that in every single one of the disorders we've talked about before. So that's definitely a sign of something more serious going on. Pain, hoarseness. Okay, it says initial symptoms are often non-specific with persistent cough and kind of attributed to another cause, right? So kind of these sort of weird symptoms that you don't really know why they're happening. Okay, and for diagnosis, some of the same things we talked about, but a CT scan is important. If you do see a tumor in that CT scan, you may have to aspirate that to see if it's cancerous. Surgery, chemotherapy would be treatment. Okay, and so if you look at this sort of staging system for lung cancers, you can see how, we talk about stage 4, lung cancer or stage 4 breast cancer. This is some idea in terms of how these stages are sort of designated, right? So it's showing you here your sort of, primary tumor here, right? And then, wait 1 second. Sorry, guess that green is showing you, yeah, what the green is showing you is lymph nodes. I just wanted to double check that, but I'm pretty sure that's what that's showing you. So all those little green dots there are lymph nodes there, right? And so you kind of just see that primary tumor for stage 1, right? Yeah. And there is nothing in the lymph nodes, right? If you look at stage 2, here's your primary tumor. Now you see it in lymph node, right? Now it's moving to more lymph nodes. Then when you get to stage 4, it's pretty much kind of all over the lymph nodes, right? And now you may start to see it going to other organs like the brain, the liver, and the bone. Okay. So again, lung cancer, we all know what this is caused by, an overgrowth of cells, again, particularly in the lung, okay? Now, tuberculosis, right? Obviously, it's not a cancer, okay? So we're switching gears here. It is a infectious disease, okay? So it is caused by a bacteria. There is the name of the bacteria. You've probably talked about this in microbiology, right? M. tuberculosis bacillus, and that's where the name tuberculosis comes from. Again, it primarily affects the lungs. Whatever, if you kind of first have the infection, I guess this is kind of saying they're in the lung, but maybe no significant tissue damage. However, as you sort of move on and you actually have the disease, you end up having significant tissue damage in the lung, and it is highly contagious. Okay, in terms of risk factors, if you have an immune disorder like HIV or AIDS, foreign immigration, meaning in areas of the world where this is prevalent, low income, homelessness, malnourishment, all of these things will contribute to the disease. So the thing with TB is that it can remain dormant for years. So the bacteria is in the lungs, but again, not causing any tissue damage, and you don't actually see any symptoms. But then it can later turn into active TB. Okay, and so it's only that active TB that would be contagious and that you would see symptoms with. Okay. One of the things, if you look at a CT scan, you can see some of these a granuloma or granulomas that form, and we talked about those before in a previous chapter, but they're basically just small areas of inflammation in the lung that you can see with imaging. Okay, so if you look at the pathogenesis of tuberculosis, there's a couple slides here that show it, and I think it's important to kind of understand what's going on here. Again, do you need to know every single detail in here? No. Definitely not. Okay, this is showing you though inside, so this is the alveoli, right? And you can see the bacteria in here, right? Okay, so it's there, and so now we start to see what? Some inflammation, right? Some immune cells coming along, and so what are these guys doing? They're engulfing that bacteria and getting rid of it, right? As you move along here, so yeah, you got some immune cells that are trying to engulf this bacteria or whatever, but the bacteria is still growing, right? And you got more of these bacteria around, and basically the immune system is not able to, keep up with the bacteria, and it's not able to get rid of it, right? And so that's what this is showing you here. Again, you kind of have this cavity where you have all this stuff going on, and then what can happen is the bronchial wall can rupture, and now it gets out, right? And can move to other places. Uh-oh. Okay. All right. Sorry, that's it. I thought there was another slide of that. Okay, so in terms of clinical manifestations, again, if you talk about active TB, latent TB means that you have the bacteria there, but there's actually no symptoms and really no tissue damage that has occurred yet, okay? But if you're talking about active TB, cough, weight loss, right? Fever, night sweats, dull aching chest pain, okay? Coughing up blood. Again, if you're latent, you don't have symptoms. However, there's some trigger, right? So maybe your immune system becomes weakened and then you end up with the symptoms and the full-blown active TB. Maybe there's some other virus that you're exposed to or some other environmental factor that will trigger that active TB. So for diagnosis, physical exam, chest x-ray, in terms of medications, right? Antibiotics, this is a bacterial infection, but also the vaccine, right? You can have that. So if you're in areas of the world where TB is prevalent, you probably would be beneficial to have the vaccine. Okay. This is really just one slide here, but there are fungal infections that can happen in the lung. And you see this more in immunocompromised individuals, okay? But it can happen in healthy people as well. And basically, you can inhale fungal spores, right? And it can cause basically dysfunction and tissue damage. And so these are just giving you some examples of some of them. Don't worry about those things, but these are just different exposures. And again, these aren't bacteria, right? These are fungi. And so you can notice the names of these. So coccidioid mycosis, right, name for it, but basically these are named after the types of fungi that cause these diseases. So just like tuberculosis named after the bacteria, these are, I guess, certain outbreaks or fungal infection outbreaks that happen and the fungus that cause them. I'm not going to ask you guys about the name of specific funguses or anything like that, but I just want you to understand that not always, would it be a bacteria that could cause infection? Of course, there's viruses, but also fungi as well. Okay. Here's another, so I just mentioned virus, right? There are, viruses that can cause bronchitis and things like that. And we'll talk about that a little bit, but croup, I don't know if you guys have ever heard of croup or croup cough. It kind of has this characteristic sound to it, but caused by a virus, okay? A lot of times you see this in children. And again, it's transmitted, pretty easily by direct contact. Again, if you're coughing in your hands, you're not washing your hands and you're touching somebody or coughing on somebody. And basically you're getting some airway obstruction, fever, dyspnea, restlessness, and this weirdly sounding cough. Okay. So if we focus a little more on some other infectious diseases of the lower respiratory tract, I just mentioned bronchitis. And we talked about bronchitis before too, right? And so again, it can really be caused by anything. And again, what's bronchitis? Inflammation of the bronchi, right? So viruses, bacteria, fungi, just like we talked about, can cause bronchitis. And again, if you kind of talk about how serious the bronchitis might be, you know, it depends on age, depends on health status. There are certain times a year where you'll see this more because of the viruses and bacteria and more of them being around. Okay. Okay, again, all these things are going to put you at higher risk. Don't worry about this here because I forgot to kind of clarify what this is. For pathogenesis, right, it says alveolar macrophages are the primary defense. Again, any virus or bacteria that's going to get in there, there are macrophages in the alveoli, like I showed you with tuberculosis, that are going to engulf that, whatever that is, and try to get rid of it, okay? Again, some of the clinical manifestations, a lot of what we talked about before. Okay, so if you talk specifically about acute bronchitis, again, one second. Yeah, so, okay, so sorry. This was really just specifically, or in general, talking about lower respiratory tract. Now this talks specifically about bronchitis, okay? But you're going to see there's overlap between, okay? In terms of infectious causes, like I said, bacteria or viruses, right, can cause it. Also, asthma, air pollutants can also trigger bronchitis, okay? So it doesn't always have to be a bacteria or a virus. Again, what does it mean? It's just inflammation of the bronchi, right, of the bronchioles. Okay, you have a sore throat, you have congestion, chest pain, and basically, you know, if you have bronchitis, you have a serious case of bronchitis, you want to make sure it's not pneumonia, and so you would do a chest x-ray to make sure, or to differentiate between the two. Okay, so again, this is you know, of the bronchi here. If we go down a little lower, right, and we go to the bronchioles, basically, you can, hence the name, right, bronchiolitis instead of bronchitis, which is bronchi, bronchiolitis, which is the bronchioles. So again, further down, right? You may see this a lot, again, with cystic fibrosis, okay? It will occur more in sort of high-risk adults like smokers, or again, somebody that has a disease like cystic fibrosis or some other compromise to the lung, okay? I mean, again, I think we haven't heard of this very much, but we've heard of bronchitis a lot, right? So bronchitis happens a lot to healthy people. This you won't see as much in a healthy person, but it could happen. Okay. Okay, so again, it says necrosis of respiratory epithelium. So those epithelial cells are dying, right? Again, excess mucus production, okay? In infants, you would want to be, you know, you would be particularly concerned with, and it would be fever, tachypnea. Older adults, cough, nasal discharge, and you would hear these crackles. All right, so another infectious disease here, right? Pertussis or whooping cough. Again, most of us have a vaccination for this. You know, caused by a a virus or whatever that will that will produce a particular toxin, right? Pertussis toxin, and can lead to uncontrollable cough, basically this sort of weird whooping sound. Okay, again, the only treatment is vaccination. Right? The primary treatment is vaccination for this. Another one, influenza. So I just want to kind of keep reminding you of these different types of infectious disease. That's really all this is meant to be. I'm, again, not really concerned with you guys knowing too many of the details in here. It's really just identifying what type of disease something is. Again, knowing that tuberculosis is not a restrictive lung disorder, that it is an infectious disease, okay? Knowing that cystic fibrosis is not an infectious disease, it is a genetic disorder, okay? So we want to just be able to categorize these things, and that's why I say that that unit 6 summary is particularly helpful because it actually gives you these examples and categorizes them. Okay, so if you talk about the flu, again, viral infection. Okay, and you know, most of us probably get the influenza vaccine, though it usually doesn't protect you against all these strains. There are many different strains that are going around. For the most part, healthy people really aren't at risk for, you know, to die or anything like that. But if you talk about older population and really young, there, you know, again, if it's serious enough, there is a chance that it could lead to death. But for the most part, we can deal with the infection and overcome it. All right. So again, some of the same things we talked about before, right? You're going to have some epithelial cells that are going to end up dying and some, you know, damage there. And then a release of inflammatory mediators, which then leads to the clinical manifestations here that you might have. Okay, what's the treatment? There is an antiviral therapy that you can be given as long as you take it early on in the course. It will shorten the duration of the disease, but usually, you know, there's not really much you can do except drink a lot of fluids, right, rest, and kind of promote your, you know, healing yourself in terms of your immune system being able to fight that off. Again, there is a vaccine, and so that's the other line of treatment. All right, so if you talk about pneumonia, we talked about kind of doing a chest x-ray to distinguish between bronchitis and pneumonia, okay? So inflammation of the lung parenchyma. So again, bronchitis was just bronchi, right? Now you're getting to sort of more serious here. And so you'll have the alveoli filled with you know, mucus essentially. There is, you know, it depends on how serious it is, again, what the age of the patient is, but there is a hospital-acquired pneumonia that can occur. Again, in terms of risk factors, we talked about it as well. So if we, again, just to kind of look at the difference here, we're talking about the alveoli now. Okay, so you can see there's a whole bunch of stuff going on in there, and a whole bunch of kind of you know, stuff kind of clogging those alveoli. All right. So in terms of classifying it, I don't know that we really need to worry about classifying it, but you can imagine that this might be the way you would classify it based on the pathogen that causes it, right? Can be caused bacteria or viruses. Again, this is much more serious than bronchitis. Okay. Again, some other types of sort of causes of pneumonia. Again, I just want us to be able to identify and categorize these, okay? Can be bacterial, can be viral. All right. So again, if you look at this, this is showing you a bacterial pneumonia, okay? So again, you're exposed to the bacteria, aspirated into the lungs, inflammatory response, showing you this sort of alveolar edema, this buildup of fluid, and then all that exudate that's going to form. And then, you know, you got a whole bunch of stuff in the alveoli, like you saw in that other picture. Okay, so the respiratory bronchioles, the alveoli are all filled with this thick fluid and blood cells and a whole bunch of other stuff. Okay, again, some of the clinical manifestations. All right, the last, I hope this is the last part we're going to talk about, is a pulmonary embolism here, because again, now we're out of infectious disease, right? So again, categorizing things. We know that pulmonary embolism is not an infectious disease, okay? So here you're going to have a clot or an embolus that will lodge in the pulmonary artery. It will then block circulation to the lung, okay? Again, if you're immobile, you just had recent surgery, okay? Even oral contraceptives can put you at higher risk for this, okay? These are all going to increase the risk of developing a blood clot and then it breaking off into the lung. All right, so just to continue with that. So again, these are all increased or risk factors for a pulmonary embolism. So again, that embolus will break off and it will then lodge itself in a pulmonary artery, right, in a pulmonary vessel, and it will basically impede blood flow. Okay. It says for clinical manifestations, again, it kind of depends on how big the clot is and where the blockage is, but sometimes you might not have much in terms of symptoms, or kind of not know what's going on, maybe some shortness of breath. Here again, coughing up blood. In terms of diagnosis, again, scanning, right, imaging, a CT scan with contrast to basically look for that blockage. For treatment, it's anticoagulants, right? So blood thinners, okay, preventative measures, all these things in terms of, like I said, blood thinners or things that are going to basically bust those clots, and then preventative measures, right? So if you smoke cigarettes, you're at a higher risk, so you need to get rid of those cigarettes. If you are sedentary, moving around is going to help with this as well. Okay, if you talk about contusion, right, this is just bruising of lung tissue, so this is due to injury. So motor vehicle accidents, explosions, you'll actually, it can actually be a lethal chest injury, and over time, it can lead to respiratory failure. Okay, so that's the end of that chapter, and like I said, I'm going to move on. I think the other ones are a little bit shorter than that one. Sorry for that one being a little bit long. All right, so chapter 20 is respiratory failure, okay? So in terms of respiratory failure, what is it? Again, you got inadequate gas exchange, and you have hypoxemia, okay, either with or without hypercapnia. So hypoxemia is obviously a decrease in oxygen in the blood. Hypercapnia is an increase in carbon dioxide. We had that term before. You talk about type 1 respiratory failure. So I want you guys just to know the basic difference between the two. Type 1 respiratory failure, hypoxemic respiratory failure, and basically it's hypoxia without hypercapnia. Okay, so you have a decrease in oxygen levels, but you have no change in carbon dioxide levels. If you talk about type 2 respiratory failure, or ventilatory respiratory failure, you have a decrease in oxygen and also an increase in carbon dioxide in the blood. Okay? If you're talking about acute respiratory failure, it is an immediate threat to life because the body is not going to be able to get oxygen to the tissues. It says implications here, right? Cardiac system, because if you have an increase in carbon dioxide in the blood, it's going to lead to pH changes, right? And so the kidneys will try to compensate for that change to get that pH back to where it would be. It's going to affect neurologic status and also fluid status as well. And so if you look at this sort of concepts here related, you can see some of this before, right? So we just mentioned acid-base balance. Okay, again, if you can't get that pH back to where it was, it can lead to respiratory acidosis, right? If you look at sort of comfort and pain, showing you some of these things that you might find there, and also effects in cognition, because why? You're not getting enough oxygen to the brain. Okay, again, like I said, for type 1 respiratory failure, severe hypoxemia, okay, in terms of the number here, the oxygen levels, less than 60 millimeters mercury. If you talk about type 2 respiratory failure, again, you also have an increase in carbon dioxide levels, okay? So an increase in carbon dioxide and a decrease in oxygen in type 2. In type 1, it is only that decrease in oxygen levels, and there is no change in carbon dioxide levels. Okay, we already pretty much said this. I think that I just wanted to make sure we sort of reiterated this. This also talks a little bit about kind of why this happens, and some of it in terms of why you don't get a change in CO2 with type 1, or why you don't see that all the time, is because carbon dioxide will actually be able to diffuse faster through the cell membrane, and so it takes a lot more for that to sort of build up in the blood. If you talk about, the amount of, and again, those low levels of carbon dioxide, if an individual is hyperventilating, right, in response to this hypoxemia, that means you're going to have an increase in ventilation rate, an increase in respiratory rate, or an increase in the amount of breathing that's occurring. You're getting that carbon dioxide exhaled. That's part of the reason as well. Okay. If you talk about type 2, right, hypoventilation, meaning you have a slower respiratory rate, and it says inadequate alveolar ventilation, you have that CO2 that gets built up and ends up accumulating in the blood. Okay. Again, we mentioned this acidic pH, and we mentioned this before too. Why is it dangerous that you have this buildup of carbon dioxide in the blood? Because it drastically will change that pH. Okay, and I mentioned this before too, that the kidneys will then try to compensate for that change in pH. Okay, so if you're talking about sort of, there are things that are going to obviously cause respiratory failure or contribute to it. So you want to find out what that is. Common signs and symptoms, things we've talked about all along in all of these respiratory chapters. Okay, to confirm respiratory failure, you need to obviously measure blood gas levels, oxygen levels, and carbon dioxide levels. You need both of those measurements to determine whether it's type 1 or type 2, like we talked about. What are you going to do to manage respiratory failure? You have to improve oxygenation, right, and restore normal ventilation. Give some supplemental oxygen, maybe bronchodilators, altering positions in the bed. So they're all, you got to get rid of any mucus that might be built up, and maybe you might even need a ventilator. Okay. Okay, so this next part talks about some disorders that cause respiratory failure, okay? So here's one, acute respiratory distress syndrome, or ARDS, okay? You have severe inflammation that will lead to increased pulmonary vascular permeability. So what does that mean? We're talking about movement of oxygen and carbon dioxide, or particularly oxygen, right? Moving from the alveoli to the blood, right, and vice versa, right? Carbon dioxide moving from the blood to the alveoli to be exhaled out, okay? So risk factors, you may see this in pneumonia, okay? Also in sepsis. So again, this isn't something that sort of stands alone, and I think a lot of these things aren't, right? So if you have pneumonia or sepsis, again, due to exposure probably to some bacteria, right? You can then end up with this acute respiratory distress syndrome. But there are other reasons as well. Aspiration, right, which is choking. Near drowning, again, that's essentially liquid or water that you're choking on, right? Okay, so in terms of acute respiratory distress syndrome, in terms of pathogenesis, again, it's kind of showing you that you kind of have this sort of introductory sort of phase, and then this more sort of serious phase where you have more and more damage that's occurring. Okay, again, continuing with the different phases of ARDS, and we have a picture here to just show you that. Okay, so again, I don't want you guys memorizing these phases and what exactly is going on at each one of the phases. Let's look at it in a picture form. You can see this here. Okay, so again, we're talking about it's starting in the alveoli. Okay, so you have some of these, immune molecules that are released by the macrophages there that are going to start causing problems, right? What then happens is you basically get all of this fluid buildup, right? And kind of thick mucus buildup in the alveoli, right? So it's kind of showing you here now, this is kind of the start of some pulmonary edema, okay? Again, you're getting all of this fluid that builds up in the lungs. Eventually, again, if too much of that fluid builds up, right, those alveoli can collapse completely, right? So again, you've lost the entire gas exchange surface of the lung here. So you can see this oxygen kind of is supposed to come down here to the surface of the alveoli and move into the blood vessels here. It can't get there because there's all this goopy fluid there. Okay, and again, this is kind of just showing you end stage. There's nothing that can occur anymore. Complete damage here. Oxygen can't go anywhere. Carbon dioxide also can't be exhaled out. Okay, it says progressive hypoxemia despite increasing FiO2. Bottom line is this is, because I just want to make sure you guys know what they meant by this. Basically, it is a increase in the amount of oxygen in the air. So if somebody needs oxygen, right, you give them oxygen, that's what this is telling you, right? So it's not normal atmospheric levels of oxygen, it's more oxygen. So if you're increasing the amount of oxygen you're giving that patient, but nothing is changing, that's one of the clinical manifestations. And again, you can see why. It doesn't matter how much oxygen you give that patient, it will never move into the blood vessels and into the blood. Okay? All right. It says here, bilateral pulmonary infiltrates seen on the chest x-ray, right? You can see all of this accumulation of stuff there. But there is no evidence of heart failure, right? So you kind of you have this pulmonary edema, but it's not due to heart failure, okay? It's due to this acute respiratory distress syndrome. So again, you have to make sure you differentiate to kind of what I just said, right? Between acute respiratory distress syndrome and some type of heart failure that's causing this pulmonary edema. Okay, so it's difficult to differentiate these clinically. So one of the ways that they differentiate them is by looking for brain natriuretic peptide. So if there are low levels of this, it will confirm congestive heart disease, right, or congestive heart failure. So you don't see low levels in ARDS. Okay, so that's one of the ways it would distinguish. Also, if you look at an EKG, would indicate and could indicate heart failure, but not all the time. But again, you're not going to see changes in EKG with ARDS, right? And so, so that would help distinguish as well. Okay, what's treatment? Intubation and a mechanical ventilation. Okay, because again, there is no way the lungs are not functioning, right? That oxygen doesn't matter if you give the patient oxygen because it can't get through or even down to the alveoli, right? Because they're essentially damaged and destroyed. Okay. All right. There are ventilator-induced injuries that can occur with that treatment. You can also have, the specific respiratory distress syndrome that can happen in infants. Obviously, super serious, but basically you have this deficiency of surfactant. And so because that immature lung can't produce this surfactant, and I believe I have it in the notes there in terms of what that surfactant does, it kind of produces this sort of sticky surface that basically decreases the surface tension at the alveoli. And so without it, your lungs cannot function properly. You end up with inflammation and also pulmonary edema. So this is kind of showing you here. And again, you see this a lot more in premature infants that, again, do not produce enough of this surfactant, which then leads to all of these things here. Okay. Okay, and these are some of the clinical manifestations. Rapid breathing, shallow breathing, shortness of breath, cyanosis, we talked about that before, okay, apnea. All of these are signs that there is some sort of respiratory distress going on. Okay, in terms of diagnosis, again, measuring oxygen levels and carbon dioxide levels, and also in X-ray. Treatment, surfactant therapy, because again, that's the main problem, is that surfactant, that there isn't enough of that surfactant being produced. Okay, I already mentioned pulmonary edema. Again, want to just make sure we mention it again and we understand what's going on. It's accumulation of fluid, right, in the interstitial spaces and also in the alveoli. We saw that, okay? And so what happens is, you get sort of this backup of blood, right? So if you have left ventricular failure, so your left ventricle is not able to pump that blood out into circulation, basically the blood backs up in those blood vessels. It never leaves the blood vessels, but then that causes leakage of fluid out of the blood vessels that then accumulates in the lung, okay? And again, this has to do with decrease oncotic pressure because that has to do with the amount of blood proteins that sort of accumulate there, and it throws off all these concentration gradients. And because of that, you get this fluid leakage, okay? Okay, and so that's what this is saying here, right? Fluid accumulates in the alveoli and leaks into the lungs. We already kind of saw that in a picture here, but basically you get this buildup of fluid. Okay, some of the same symptoms we saw before. Okay, again, some of the same clinical tests, but I guess kind of one here is showing you serum albumin levels, because again, you're going to see that you have higher or alterations in those albumin levels, which again is just a blood protein or plasma protein, and that's going to throw off concentration gradients and let that fluid, or allow that fluid to sort of leak out of the blood vessels and accumulate in the lungs. So this gives you information on whether it's pulmonary edema or some of the other things that we talked about before. We already talked about COPD. Just sort of, a reminder here that if you're talking about stage 4 COPD, right, you have basically damage to the alveoli. They're completely broken and completely damaged. Okay, so you'll see some of these more serious symptoms start to occur in the advanced COPD, and we talked about this already. All right. Okay, so I believe we have one more here, and this is chapter 21. Again, I really am only concerned with you guys being able to categorize, or mostly concerned with you being able to categorize these. All right. So oxygen transport, right? So we haven't really talked much about this, and I think this is a good lead-in to our next chapter, our next unit, which is disorders of perfusion. So I wanted to make sure again that I mentioned some of these. We've all heard of anemia before, right? It's pretty common, and there are a couple different causes for anemia, and basically it's a reduction in the number of red blood cells, right, or erythrocytes, and a decline in the ability of those red blood cells to carry oxygen. Okay, and so again, there are different causes of anemia, different types of anemia. If you talk about anemia caused by a nutritional deficit, particularly a deficit in iron, you need iron to complex with forms complexes with oxygen and hemoglobin and myoglobin, and so it's necessary there because it's this heme group this iron group is part of the hemoglobin and the myoglobin. Okay, so without iron, hemoglobin and myoglobin lose their ability to transport oxygen, okay, or their ability is decreased. Okay, so again, what's going to happen? You have loss of oxygen in the tissues because those red blood cells are not able to carry that oxygen like they should. You have loss of red blood cells, okay, and okay, so we already said that, right? So genetic variation here, it says prevents formation of mature erythrocytes or hemoglobin. So you can actually have a problem where you don't make or you don't form those mature red blood cells, or you're not producing a functional hemoglobin protein. Okay. You can also have misshapen erythrocytes, and they basically will clump together, and they can lead to ischemia and hypoxia. If you talk about, so these are all kind of red blood cell disorders in general, right? So this is all pertaining really to anemia here, and these are different causes, right? You can also have red blood cell disorders where you have too many red blood cells, and that can cause the blood to thicken and again compromise the oxygen carrying capacity of the blood. So if you look at normal red blood cells, right, they have this sort of slightly flattened kind of donut-like or disc-like shape, okay? And we'll come back to the shape thing in a second in a few slides, okay? So if we look at sort of anemia in general and things that are related to it, you can see, again, this is all stemming from a problem with oxygenation, not because you can't get oxygen from the alveoli to the blood, but because in the blood, there is a decrease in that oxygen carrying capacity of the blood, right? And you can see all of these different types of issues you're going to have that go along with anemia. Like I said, this is really good lead into our next unit. Okay, so decreased production of erythrocytes, reduced survival time of erythrocytes. So they're made, but they don't hang around as long as they should. Loss, right? So loss of red blood cells. So for whatever reason, you're decreasing the number of overall red blood cells. Again, you can also have changes in the structure of those red blood cells. So they're misshapen, okay? So there are a bunch of different laboratory tests that you can do in terms of measuring red blood cell numbers, measuring hemoglobin levels, okay, that can identify the cause or kind of or the risk for anemia. And so these are some of the tests. Again, we're not going to go through all of these. I did mention, you know, the number of, you know, hemoglobin levels, right? Hemoglobin levels, but also the number of red blood cells. So again, you could potentially have a normal amount of red blood cells, but a decreased amount of hemoglobin or non-functional hemoglobin that can basically decrease the oxygen carrying capacity. So it doesn't always, so you kind of have to look at both, okay? If we just a reminder in terms of what blood is made up of and these, and you know, blood cells here, right? So if we look at formed elements, which are all the cells, right? Red blood cells, white blood cells, and platelets, about 45%. Basically, this sort of protein, well, so this sort of middle layer that happens, this is showing you when you spin it down, right? Centrifuge that blood sample. And then plasma, about 55% here. And you can see what's in the plasma, right? Proteins, mostly water, other solutes as well. And again, what we're particularly talking about are erythrocytes, the red blood cells. And you can see there are many, right? So there's about, you know, 4 to 6 million red blood cells compared to, you know, 10,000 white blood cells. Okay, so if you talk about nutritional deficits, like I told you, iron deficiency, but also other types of nutritional deficits, vitamin B12 and folic acid can also lead to anemia, okay? If you have a reduced number of stem cells, another type of anemia called aplastic anemia can form. Medications, radiation can also lead to anemia, okay? Chronic diseases can lead to anemia. So I want you guys to have an idea of kind of the different causes of it, okay? If you have just, you know, blood loss due to an injury or something like that, again, can lead to anemia, okay? All right, so again, it is a reduction in the ability of these red blood cells to carry oxygen, okay? So what happens as a result of this? All of these things here, again, increased respirations because your body is trying to make up for the fact that you don't have enough oxygen in the blood, right? Headache, dizziness due to that lack of oxygen, okay? Fatigue, muscle weakness, these are very common clinical manifestations of anemia, okay? I'm sure you've heard people say that, oh, I was tired all the time, right? And went to the doctor and they basically, you know, they'll test my iron levels and my, you know, red blood cell levels and hemoglobin levels to see if it's anemia. Okay, now you can have anemias that are, so this is hemolytic anemias, right? So hemolysis of the red blood cells. So basically they're breaking up, right? So physical trauma, stress to the red blood cells can basically destroy them. Disruption of hemoglobin formation can then again affect the red blood cells as well. Most of the hemolytic anemias are genetic, okay? Okay, so again, we talked about anemia. We mostly think of anemia as being caused by nutritional deficiencies. Yes, that's true, but that's not the only type of anemias there are. I mentioned aplastic anemia, where basically your body, you just don't make the red blood cells. You also don't make other blood cells as well. So if you talk about in your bone marrow where you have these blood stem cells, you're not making the cells that you need, okay? I'm sure we've all heard of sickle cell disease or sickle cell anemia. Again, worth talking about. So it is a autosomal recessive disorder, again, a genetic disease where you have this sickle shape of the red blood cells, okay? And again, the hemoglobin can't bind oxygen effectively, right? So it doesn't mean it doesn't bind it at all, but it's not very effective due to the sickle shape of these red blood cells, okay? They also then have the tendency to clump together and obstruct blood flow. So you kind of have the combination of those two things. Oxygen can't bind very well because of the size, but also all of those sickle-shaped cells have the tendency to clump together. Also, the lifespan of the red blood cells is only about 10 to 20 days compared to 120 days, okay? Also leads to chronic inflammation as well. Okay, so this is the sort of sickle shape that you see of these red sickle in sickle cell anemia. Again, nobody needs to know in specific details here, but the idea is, you know, this is showing you a pedigree, right? Because we said it is an autosomal recessive disease, okay? And you can kind of follow along here with, you know, somebody, these are a mother and a father that both have sickle cell disease, right? And again, autosomal recessive, and you can kind of see who's affected and not in their children, right? So T means they have the trait, N means normal, and this means they have sickle cell disease. So here again, light purple, they carry the recessive version of this gene, right? They are not affected themselves. If you look at their offspring, they had one that's completely normal, two that have the trait just like them, right? One normal allele and another disease allele, right? And here, this person with sickle cell disease, right, would have two recessive alleles. Okay, we talked about this again in an earlier chapter. Okay, and so if you look at this here again, just kind of hitting home the point of what's sort of happening here, and this is talking about hemoglobin, right, synthesis. Again, it is a defect in the gene that produces hemoglobin, produces that protein, okay? And so there are incorrect amino acids in that protein, which then affect the folding of that protein, okay? And then obviously also affect the function, okay? So you have this misshapen hemoglobin protein, okay? And basically, this is what ends up happening. Again, oxygen can't bind, and it causes these red blood cells to end up being sickle-shaped. And so if you look here, remember I also told you they sort of accumulate together. So you can see there's some normal red blood cells here, but then here's the sickle-shaped ones, and they will coagulate and accumulate together and can cause, you know, blood clots and obstruction of blood flow. Okay, so some clinical manifestations, right? Hypoxia, tissue ischemia. In terms of treatment, especially if it's nutritional, obviously, you can, but here we're sorry, we're not talking about that anymore. We're talking about sickle cell disease. Prevention, screening, supportive care, disease-modifying strategies, curative procedures, genetic analysis, prenatal counseling. Bottom line is you have to just sort of, you know, find ways to sort of cope with and treat the disease, right? So the supportive care in there, but also the genetic analysis and prenatal counseling is important too. And the severity of the disease will vary with patients as well. Okay, but again, it's important to know, is your partner also a carrier, right? What are the chances of you having an offspring with sickle cell disease? All right, we're not going to worry about going through this disease here, but these are some other types, of disorders here. I mentioned aplastic anemia before. Again, you basically have a decrease in all of these blood cell populations. So white blood cells, red blood cells, and platelets. Your body is basically not even producing new blood cells, right? So in your bone marrow, you have your body throughout life keeps producing these new red blood cells. And obviously, if that stops happening, it's major, and it is a really, really big problem. And there are various causes. Genetic predisposition, but maybe some sort of viral exposure, some sort of drug or toxin that might trigger this. Okay, so to diagnose this, again, if you're talking about aplastic anemia, you don't only see a decrease in red blood cell number, you would see a decrease in every single type of blood cell, okay? All right, so this is going along with these hemolytic anemias. Again, like I said, if it was nutritional, sure, take in more iron, right, or whatever that deficit is. If you're talking about hemolytic anemias, it's a little bit harder to treat, right? Blood transfusion can work. If you're talking about sickle cell disease, again, blood transfusions, stem cell transplantation, because it is a genetic defect, right? You're not producing those red blood cells are misshapen due to that problem with hemoglobin. So there's no really drug that you can take to reverse these effects. Okay. All right.